Thank you for joining us for Conversations in Relapsed Refractory Multiple Myeloma. During this segment, we'll be discussing introducing, optimizing, and sequencing bispecific antibodies. My name is Dr. Joseph Mikhael. I'm a professor at the Translational Genomics Research Institute. And with me today are my dear friends and myeloma experts, Dr. Jesús Berdeja and Dr. Saad Usmani. Well, it's always good to spend time with the two of you, no matter what we're doing, but especially when we get to talk about some of these novel treatments we've been discussing, bispecific antibodies, these unique molecules that can engage the T cell from the patient as well as their myeloma cell in one off-the-shelf shot. So just sort of thinking on the bigger side, remember our topic is introducing, optimizing, and sequencing bispecific antibodies. If I want to have a myeloma conference today where people are going to attend, I will tell them that we have the optimal sequence of relapsed myeloma, and they'll come hoping to find an answer. We know that there's no perfect answer, but at the same time, I'm really interested in both of your thoughts around it. When we look at sort of the big picture of relapsed myeloma, we have proteasome inhibitors, immunomodulatory drugs, and CD38 antibodies. Now we've introduced selinexor and even CAR T cell therapy. So when bispecifics very quickly on the heels of CAR T came into your practice, maybe starting with you, Saad, how did that change the way you've approached relapsed multiple myeloma? What difference did it make in your practice once we started having the monoclonal or the bispecific antibodies?
Thank you, Joe. I think when the bispecifics came into our clinical practice, all of us were struggling to find that next best option for our patients. We had a BCMA-directed antibody drug conjugate, which was taken off the market, and we had long wait lists for BCMA CAR T cell therapies. So having the bispecific as an option helped us alleviate, that issue. For patients who needed a BCMA-directed treatment right away, we were able to offer them that bispecific therapy. And then, I think that also helped us in prioritizing, which patients would be able to actually get to CAR T cell therapy, because it does require a logistic window in which their disease is well controlled. So it was, a blessing really to get the bispecifics into our clinics.
That's great to hear. I mean, that sort of off-the-shelf advantage was obviously huge. How about yourself, Jesús? How has it influenced your approach? I mean, in a few minutes, we're going to talk about kind of the sequencing side of things, but how has it changed the way you sort of approach your patients now with relapsed disease?
Yeah, no, I mean, I had the same experience with having that option to treat right off the shelf was very comforting for both me, our patients, and myself. But having said that, I have a lot of patients that come specifically for CAR Ts and CAR T trials, right? And so people get addicted to CAR Ts. They like being off therapy. And so it's really interesting because I found that it goes both ways. Some patients are petrified of CAR Ts and really would only want to bispecific. So at least in my experience, oftentimes the disease doesn't chooses for you. But if the true options are there, it's really a conversation with the patient and really what their preferences is in terms of which way we're gonna move forward with. Obviously, we'll talk more about sort of the data in terms of which one, if we have both options, which ones we should choose first. But at least for me, it was wonderful because then for the patients where we had a choice, we've now had a new choice. But then for a lot of those patients where even if the first choice was not a bispecific, it was an excellent choice for them that was available right away.
It's beautifully said, man. I mean, you can pretty much drop the mic there, right? I mean that's the whole. If there's one message I think we want to convey very clearly is that the more the better in myeloma in terms of options, right? In a disease that we've still not cured, we want choice for our patients, and sometimes that choice, frankly, has to be guided by the biology of the disease. But more often than not, it really is a discussion with the patient where we have lots of choice. Historically, going back in time, we didn't have a lot of choice in myeloma. We had one or two drugs, and that was pretty much all we had. Now we're exceeding 20 of them. And thankfully, I think the modality of a bispecific, of engaging the immune system, the T cells that way, without the sort of, big bang of CAR T, despite the fact you said beautifully, Jesus, it comes with that really nice one and done like approach, although we know it's not really done, but we still call it the one and done approach. That is really attractive to some. Others are like, no, I'd rather just get, a bispecific antibody. We can go straight off the shelf. There's no delay in waiting time. Sometimes that 8 weeks is a long time to wait for a lot of patients. So I think that you've captured that really nicely in terms of the overall benefit of being able to do so in a patient friendly manner. But let me create some scenarios for the two of you, and I could ask each of you to answer each scenario. You're not going to be held, to this for the rest of your careers. But in what we know now, and I will add that as a caveat, that there is no drug we use in myeloma today the way it was first introduced. Right. I mean, it got its invitation to the party, but then inevitably there was a change. Right. And so, when I look at, we used to give bortezomib IV twice weekly. We used to give carfilzomib once weekly or twice weekly. Selinexor we gave twice weekly. Now we give basically those drugs always once weekly. We used to give drugs at much higher doses, now typically lower doses. And in all of those examples, daratumumab IV to sub-Q, we're trying to increase efficacy and reduce toxicity at the same time. I think we're still in our learning curve of bispecifics. So I'll put that caveat off the start so that people, the tens of thousands of people participating in this educational activity and who will be listening are not going to hold Berdeja to his choice. But nonetheless, I do want you guys to try and commit a little bit in each of these scenarios. So let's start with the most common, if you will, scenario in a patient who is triple class refractory, who's met the criteria that way. We'll come back to how many lines of therapy they've had later, but just someone who has never seen a BCMA targeted agent. What is your favored thinking in that patient, all things being equal? Maybe we'll start with you, Saad. Would you go to CAR T? Would you go to bispecific? Would you go to belantamab as an antibody drug conjugate? What's your general thinking there?
So, part of this will obviously depend on, patients, age a little bit and whether, they're CAR eligible or not. But if this was utopia and access was not an issue and doesn't matter where the patient is geographically, they can get access to CARs, I would favor a BCMA-directed CAR T. Only, because, it's a little labor intensive early on, but then it provides patients a drug-free period where their quality of life really gets better. And so, that is the reason why I would pick a CAR T cell therapy for that kind of patient.
That's fair statement. Jesus, what's your thought about that BCMA naive, as it were, patient?
Yeah, so I have to say I'm struck by the data from CARTIC-2. Was it 2 cohort C, I think, that showed that with cilta-cel in patients who've had a prior ADC therapy, both a bispecific or an ADC, the response rate was still reasonable, about 60%, but the PFS was down to about 5 months or 9 months, depending on which therapy was given before. Compare that to CARTIC-2-1, where the PFS was almost 3 years. So I think given that, now granted, tiny numbers, we have very little experience, and again, these patients are all very refractory, and we may be giving things differently. I think given that, I think if we have both options, I would also give a CAR T before a bispecific.
And I think, while we're just on that, well, actually, we'll come back to that because I would like to explore this whole sequencing overall as opposed to an individual case. But let's take on that notion. So let's say that same patient ends up getting a CAR T cell therapy, whether it's one of the two that are commercially available now, ide-cel or cilta-cel. So that patient clearly has had 4 lines of therapy, and now they've had a CAR T. So they had that one and done, as it were. And sadly, as we know, despite the fact that they have prolonged remissions, they've now relapsed. what would be your next step? And this time I'll start with you, Jesus. What are you going to do? Are you going to go with teclistamab, with talquetamab, with elranatamab? Do you have a favor between them? What's your rationale and your thinking of sequence?
Yeah, I think that's unfortunately that's becoming a much more common scenario these days, right? So, and I think it really depends on how long ago was the the BCMA therapy given. So, there is data that perhaps sort of patients coming right off a BCMA therapy are going to be much more refractory to another BCMA therapy versus a patient that maybe has received the therapy 2 years prior and now is progressing where they might still be sensitive. And so in that scenario, I think going with a BCMA bispecific is fine. So either teclistamab or elranatamab. I think if there is a concern that BCMA has been lost, I think that's when you might switch the antigen talquetamab. But given the toxicity profiles, truthfully, I probably would favor a BCMA bispecific in that scenario with a very long duration of the prior BCMA therapy.
Gotcha. Saad, so you heard he's comfortable going to BCMA if there's been a longer remission to the CAR. Is that how you approach it as well, or do you see it a bit differently?
I would actually, so I agree with Jesus's, approach, and I would just, add, some important biologic information, around BCMA. So, what we typically see with those patients, who progress very quickly after BCMA CAR is they probably had BCMA mutations. And if that's the case, then, challenging them with a BCMA-directed therapy doesn't make sense, and going to a GPRC5D or another, small molecule, offering them a clinical trial, would make sense. But, if the relapse is happening after, say a median of, I don't know, 9-12 months after receiving CAR T, and the patients do have BCMA expression, then yes, I would be comfortable utilizing a bispecific, BCMA-directed bispecific antibody in that case. There's some real-world data to actually support some of that as well. And there'll be more data on that end that will be emerging, later this year. There are several, groups trying to put together bispecific real-world experiences and looking at that sequencing, question. One actually effort under the International Myeloma Working Group umbrella that all of us are part of. So yes.
Yeah, I think that'll be really helpful, and whether or not there is a easily commercially available way to test someone's BCMA expression, I think with time will be helpful. Well, Jesus, what if someone is coming off belantamab? Do you look at it differently if they had a CAR T versus an antibody drug conjugate? Are you willing to go BCMA to BCMA after belantamab?
Yeah, no, I think that's an excellent question, or I guess you would even argue from a bispecific, right? So I think it does make a difference if you're truly refractory to a BCMA therapy versus just exposed, right? So kind of our old terminology for the prior therapies, using it for BCMA therapies. That's kind of how I see CAR T versus the ongoing therapies. So if you truly are refractory to BCMA therapy, again, without not knowing whether BCMA is still expressed or what mutations may have developed, I would be more comfortable switching antigens, and I would go with talquetamab at that point.
And what, Saad, if it were not belantamab but another BCMA agent? Do you agree with Jesus? So let's say someone is now progressing on to teclistamab or elranatamab. Are you comfortable going to CAR T, or would you prefer to go to talquetamab?
So, what we've observed is patients, who are on bispecific antibodies, and we try to collect their T cells for CAR T manufacturing. Many times we are not successful, because the T cell health is not great and we have manufacturing failure. So giving a break and trying something else before, attempting a T cell collection or apheresis, is better from that standpoint. And for all of us, that's the reason why, even if, now that we have the bispecifics and we're thinking about maybe bridging our patients with bispecifics, we prefer collecting their T cells before we give a bispecific antibody to them. That's just my general approach. I put them in that same category as, giving an alkylator like bendamustine, before trying to collect them.
Yeah, no, I think you both captured it so well. So what I'm hearing from both of you is, that conversation with the patient is always important because we have choice. If we do have unlimited options, we tend to favor going from a CAR T approach then to a bispecific because of the interval of opportunity of leaving the T cells less engaged. But we do have evidence. I will say we do have data. Patients have gone from one BCMA to another and have had success, especially with these high response rate like therapies. But hopefully in the future, we'll have more data to guide us around what measures we could have that will dictate one versus the other. Well, I want to thank our two eminent speakers here for their great conversation and great insight on a complicated topic that I know has a lot of differing opinions. And thank you as an audience for joining us on introducing, optimizing, and sequencing bispecific antibodies. Please be sure to click on the landing page for this activity to claim either your AMA, ANCC, AC, or ACPE credit. You can also access the downloadable slides as well as other topics, segments, and case scenarios that are available to you. So thanks again for your attention.